From the historical perspective, how did this terminology chondromalacia come into vogue? Chondros meaning cartilage, malakia meaning softening of this cartilage. Budinger was the first to describe it. Koenig was a person who popularized it. But is it actually the terminology we should continue as we move forward? It's a misnomer actually, because it's only descriptive. It only says that the cartilage is soft. Does it mean that anterior knee pain in young adults, which is the common presentation of chondromalacia, is always because of softening of the cartilage? And the answer is no. Therefore, it is a misnomer and should not be used as commonly as we use it. It is not synonymous with knee pain. Multiple studies have shown that patients labeled with chondromalacia have actually had normal cartilage. And more importantly, we all know that the articular cartilage is devoid of nerve endings. So therefore, softening of the cartilage should not be responsible for pain. With this important understanding, then how do we call this problem of anterior knee pain in young adults? I think the best way to address it is patellofemoral pain syndrome. And that is one of the most common causes of knee pain in young adults. So as we go forward, we'll call it as PPFS, PFPS, that is patellofemoral pain syndrome, which is nothing but anterior knee pain coming either from the patella or the retinaculum or the adjacent soft tissues. Before you label a patient as PFPS, you need to rule out intra-articular pathologies, the most common being meniscal tears. This is typically a chronic disease. It's of insidious onset. It is never acute. It is because of either repetitive misuse or because of acute trauma sometimes. The exact cause of PFPS is unknown. Broadly, you can divide it into malalignment or maltracking. And that's what this whole symposium is all about. Malalignment could be in the superior inferior direction when it is either patella alta or baja. It could be in the mediolateral direction when there is patellar tilt. It could be because of torsion either on the femur or on the tibia. So excessive femoral anteversion and excessive external tibial torsion. Maltracking obviously comes into the category of instability, which also can present with pain. So clinical features, there is usually absence of trauma. There is usually lack of effusion. These two things point to an intra-articular pathology, typically bilateral, one side more than the other. The pain is dull, aching, insidious, and sometimes with a sudden increase in pain. Classically, patients say that when they sit for a very long time and get up, they experience the pain, therefore called as a moving pain. When they get up, they experience a locking or a catching sensation, which gets relieved by extending the leg. They also can complain of instability. So therefore, you'll end up checking for the ligament laxity, etc. But that is because of quadriceps inhibition. In examination, you need to do the translation of the patella. Medial translation of one quadrant or less suggests that there is a lateral retinacular tightness. You can also do the tilt test. Typically, you can tilt the lateral side for about 15 degrees. If you cannot tilt it, it indicates lateral tightness. And this lateral tightness, you will agree, is one of the most important reasons for anterior knee pain. You then do the axial compression test. So you push on the proximal patella as you see on this image. When the lesions are in the proximal patella, this will be manifested as pain in 90-degree flexion. If the lesions are in the distal area, then the patient will experience pain in early knee flexion. You need to rule out patellar tendinopathy from chondromalacia or from patellofemoral pain syndrome. You push the patella down and with your thumb you palpate the inferior pole of the patella. If there is tenderness, it is more of a tendinopathy and not a PFPS or a chondromalacia-like picture. Obviously, if there is mild instability, you need to place the knee in about 30-degree flexion and do the Fairbanks apprehension test, wherein when you push the patella laterally, patient will not allow you and hold your arm and be apprehensive. Now, this is very important in my biomechanical evaluation of these patients. I always look for hamstring tightness, and they invariably have this. Some of them also have quadriceps contractures. Gastrocnemius tightness, this is something we are not really aware, but we need to check for it. When there is less than 15-degree passive dorsiflexion with knee extension, this test is positive. Because you are doing a leg extension, it will rule out if the pain is coming from the spine and refer to the knee. So what is the pathomechanism? The gastrocnemius tightness causes increase in the patellofemoral joint force and causes a maintained flexion of the knee, continued maintained flexion of the knee. What happens because of limited ankle dorsiflexion is there is subtalar joint pronation, which causes increased tibial rotation, thereby contributing to patellofemoral biomechanics. So a foot and a gastrocnemius problem can also lead to a anterior knee pain. This is one of the most important tests, the Ober's test for the tight IT band, and obviously the positive J sign. These are the various signs you will see in patients with patellofemoral pain syndrome. If there is increased femoral anteversion, it will increase the Q angle, which will lead to lateral displacement of the patella, pain initially, then leading to instability, further softening, and then osteoarthritis. So rotational malalignment needs to be kept in mind. We all know about outer bridge classification, where there is softening, then fibrillation, then subchondral bone being exposed, and advanced osteoarthrosis. You need to look at the feet, whether they've got a heel varus and a reduced medial arch. Investigations have been covered by Sandeep. You look for the merchant view. This is a typical MRI report where we get the TTTG distance and the type of the trochlear dysplasia. Now, once we identify hamstring tightness, we are going to release it. Quadriceps, we are going to release it. IT band stretches. Most importantly, these people have got weak hip abductors and external rotators. You need to stimulate the VMO specifically for these patients, and that is very beneficial. McConnell taping is basically you put a tape from the lateral to the medial side, so you push the patella in an infero-medial direction. You then go for phase 2 rehab, which is functional rehab with the stimulator on, and then finally phase 3, where you do a isokinetic quadriceps strengthening. Orthotics are very important. A patient with a heel varus will have a worn out lateral aspect of his heel. You can give him a raise on that side and a medial arch support. This is a very nice brace called as the Donjoy True Pull Light, which helps patients with subtle instability by maintaining the position of the patella. Arthroscopic solutions are very, very far and few. We rarely do solutions for chondromalacia. But if at all you see cartilage degeneration, you can do aberration chondroplasty. Lateral retinacular release, if we have almost stopped doing this, it is out of repute. In conclusion, anterior knee pain due to PFPS is a common problem in young age. Definitive diagnosis and treatment are challenging due to the various anatomical, biomechanical, and developmental variations. You need to evaluate each one of them. Further, you need to evaluate them with radiological parameters and devise an individualized treatment plan for every patient. Thank you.